Good afternoon, and welcome to the SWOG Spring 2022 group meeting. We are together in Seattle, mostly face-to-face, mostly physical, for the first time since 2019. I cannot tell you guys how gratifying it is to give my plenary updates while being able to make eye contact with all of you. Except, of course, when I'm looking at the teleprompter, which is almost never. I can tell there's already less laughing, though. I'm going to have to resurrect my amusing story tradition if you keep it up. So we'll start with the speaker's disclosures. The theme of today's plenary is SWOG's Year of Progress, and the progress we'll focus on specifically resides in the areas of myeloma, genitourinary cancers, and our Encore side. SWOG committee leaders in each of those areas will present those updates. Drs. Robert Orlowski, Ian Thompson, and Dawn Hershman. Before that, I'll start with welcomes and farewells and update you on SWOG news and accomplishments, including recognizing numerous award winners. So on to the hellos and goodbyes. Our first farewell is to our lung committee chair, Dr. Karen Kelly. Dr. Kelly took charge of our lung cancer research efforts in 2016. As of last week, she has moved on to the role of Chief Executive Officer for the International Association for the Study of Lung Cancer. Under her hand, the lung committee made amazing progress, expanding its flagship LungMap master protocol to other histologies and activating an impressive number of new trials. Please join me in thanking Dr. Kelly for her exemplary leadership. Although it was hard to say goodbye to Dr. Kelly, it was easy to say hello to our new chair. The quality of the pool of applicants to replace Dr. Kelly as lung committee chair was truly inspiring. Among a stellar slate of candidates, Dr. Janelle Gray emerged and has accepted my invitation to head our lung committee. Dr. Gray is department chair and program leader of thoracic oncology and co-leader of the CCSG Molecular Medicine program at Moffitt Cancer Center. And she is a professor of oncologic sciences at the University of South Florida Morzani College of Medicine. She has deep clinical trial experience, including as PI of the practice-changing Pacific trial in non-small cell lung cancer, and in SWOG as co-chair of the S1900B LungMap sub-study. Please join me in welcoming Dr. Gray to the SWOG leadership team. Our next goodbye is more of a preliminary goodbye or the start of a transition process. Okay, I was expecting a huge gasp, maybe some shouts of, "Oh no, please don't go." Or at least a 6 more years chant from Jimmy Ray, but I suppose, there we go. I'm still swallowing my disappointment. As you may remember, at the fall 2018 group meeting, the Board of Governors revised SWOG's bylaws to align the group chair's tenure with the NCI grant cycle, and we changed the term limit for the chair from the previous 3 5-year terms to 2 6-year terms. That means that this, my final term as group chair, has to end with the end of this grant cycle. I did try to convince the NCI to extend the current grant by 2 more years because of, COVID, but they strangely were not buying it. So yes, the current NCTN grant covers us until early 2025. This is a bit of a lengthy horizon, but we absolutely want the incoming chair to provide the vision that powers our next NCTN and Encore grant applications. As the RFP for the NCTN grant is expected out in the fall of 2023, we need to name our chair-elect no later than the spring group meeting only 1 year from now. The bottom line, as the timeline here indicates, this summer, we will convene a search/nominating committee to identify as soon as possible the best candidates to be the next SWOG chair. I'm sure some of you read in a recent Frontline, for those of you who actually read Frontline, our proposal for updating the group chair election process to a single candidate model based on the one ASCO recently adopted. I am, however, withdrawing that proposal, and I will not present it for consideration at Saturday's Board of Governors meeting. No applause necessary. That clapping is exactly what I'm about to talk about. I presented the idea on an initial version to the Board of Governors on a preliminary call late last month. In the following week, I got tons of feedback, 99.9% of it negative. The actual percentage was probably a bit higher. The proposal was, to put it mildly, not well received, with many of you seeing it as undemocratic. Now, I don't mind making unpopular decisions. That's what a chair occasionally has to do. But it became clear to me that most board members felt the change to the election process would not suit SWOG well. I still see some potential benefits, but after consulting with members of my leadership team, I willingly bow to the voice of the majority and withdraw the proposal. I am pleased the process did spark interesting discussions that have generated other ideas that might encourage more member involvement in the election and may lead to future changes that will help ensure SWOG nominates candidates with the ideal skill set and the ideal experience for the role. And of course, what's an election year without a flip-flop or two? So with that in the rearview mirror, our bylaws do specify that our group statistician heads up the group chair nominating committee, and over the coming months, Mike LeBlanc will form that committee. Please reach out to him, if you have nominations for group chair. Self-nominations are legal and perhaps even encouraged. And so I will start the news with the news. SWOG investigators consistently publish significant research results at an impressive rate. Since our fall group meeting, we've highlighted important findings in 8 press releases, with number 8 issued just about 2 hours ago on results of the S1616 melanoma study, which Dr. Ari van der Walt were presented in AACR plenary session on Tuesday. Those results suggested in patients with advanced melanoma that has not responded to PD-1 inhibitors, moving to a PD-1 inhibitor combined with a CTLA-4 inhibitor can help overcome immunotherapeutic resistance. If you visit the news section on swog.org, you can also find releases on these other recent results. Dr. Kevin Kalinsky's landmark findings from the RxPonder trial published in the New England Journal of Medicine. Dr. Corey Spears' presentation at the San Antonio Breast Cancer Symposium on the prognostic value of the SET23 genetic assay. Dr. Megan Othis' ASH 2021 presentation on statistical models to predict benefit from non-intensive AML therapy. Also from ASH 2021, Dr. Anjali Advani's S1318 results from a new treatment combination for patients with ALL who are not good candidates for chemo. Dr. Veena Shankaran's S1417 CD findings that financial hardship after a cancer diagnosis is distressingly common. Dr. Joe Unger's findings that women are at higher risk than men for severe adverse events from immunotherapy and targeted therapy. And Dr. Thomas Flagg's ASCO GU presentation of survival data from S1314, the first prospective randomized biomarker validation trial in muscle-invasive bladder cancer. So, phew. I want to thank these investigators and their team of collaborators for their outstanding work. Let's give them a hand. Over the past year, and with tremendous support from the Hope Foundation, we've made significant advances in initiatives to enhance diversity, equity, and inclusion in SWOG. We partnered with Pope Consulting to develop strategies to make group leadership and membership more diverse and representative. We're now moving forward on a number of the recommendations that came from Pope's work. Our DEI fellow, Dr. Patricia Robinson of Loyola University, with support from a Hope Career Development Award, has been providing terrific leadership of several DEI projects, including implementing the Team Science at SWOG Module 6 methodology into our clinical trials. We brought on board 5 DEI champions to work at the level of individual committees and studies to develop plans to make our populations of trial participants more representative of our populations of patients. They are, as shown here, Gayatri Nagaraj, Manuel Espinoza Gutara, Jessica McDermott, Lucy Ganzauer, and Colmar Figueroa Mosley. We formed a DEI monitoring committee, roughly parallel to a data and safety monitoring committee, to regularly review our trials for participant diversity and representativeness. In fact, 2 DEI monitoring committee slots remain open for nominations, one reserved for a site-level principal investigator and another for a study chair. That's a not-so-subtle hint. And finally, we are engaged in a national search for a SWOG vice chair for diversity, equity, inclusion, and professional integrity to provide strategic vision and leadership to enhance DEI within SWOG. Note that was another hint. Please join me in thanking Dr. Robinson, our DEI champions, the current and future members of our new DEI Monitoring Committee, and the many, many others who are working tirelessly to make SWOG a more representative and inclusive organization. I've spoken at previous plenaries of SWOG's Plain Language Initiative, our project to seriously up our game on direct-to-patient communications. COVID-19 slowed this initiative, among so many others, but it's going forward full steam now, with the recent hiring of our plain language medical writer, Amanda Stampless. We lured Amanda away from the MD Anderson Cancer Center, where she developed patient education materials, and she's now working to develop patient-friendly summaries of SWOG clinical trials and to make our informed consent documents more readable for more of our patients. Please join me in welcoming her to SWOG. Going forward, when new SWOG trials launch, study teams and our sites will have 2 new CIRB-reviewed resources available. The first is a brief trial summary you can use when initially discussing a study with patients and caregivers. These summaries present the key information patients need to decide whether they want to learn more about a trial, and they present that information in language carefully calibrated to the average reading level of U.S. adults, a middle school level. The second resource is a social media toolkit, including text and graphics that SWOG, the study team, and sites themselves can use to spread word about the trial. Some of this content is targeted to patients in the patient advocacy community. Other content is aimed at raising awareness among investigators and ORPs at NCTN and Encore sites. These materials are available at trial activation on the SWOG website and on ctsu.org. Patients can view the summaries online, or you can print them as shareable handouts. We'll also be working in the coming months to develop these tools for the backlog of more than 40 already active SWOG trials. I could not present on SWOG news and accomplishments over the last 6 months without giving a major shout out to SWOG clinical trials partnerships. Under the leadership of Dr. Kathy Albane, SWOG CTP's preferred partnership program has been working incredibly hard, forging multiple partnerships with industry and developing protocols for trials that will test novel drugs from these partners' pipelines. By the end of the year, we expect to see several of these SWOG CTP trials launched without federal support. These will be trials independent of our NCI-funded studies, and they will not compete with those trials. They will ask scientifically relevant questions. As the trials approach activation, SWOG CTP staff will reach out to contacts at our member sites with details on how you can participate. Our member sites are the linchpins that connect us to patient volunteers, the most important contributors to our clinical trials. The sites listed here had the highest numbers of SWOG-credited registrations to SWOG-managed trials last year. Among our Encore members, these were the Southeast Clinical Oncology Research Consortium, Kaiser Permanente, Heartland Cancer Research, the Cancer Research Consortium of West Michigan, and Gulf South Minority Underserved Encore. Among our main member and LAPS institutions, these were USC Norris Comprehensive Cancer Center, the University of Texas MD Anderson Cancer Center, City of Hope Comprehensive Cancer Center, University of Utah Huntsman Cancer Institute, and the University of Rochester. Please join me in thanking all of our member sites who work hard every single day to enroll patients to SWOG trials, but especially these top 10. So let's move on to Hope Foundation Award announcements. I'll start with the SWOG Early Exploration and Development Fund Awards. These grants from the Hope Foundation Seed Fund encourage preliminary research that may translate to future clinical trials or trial-associated translational medicine studies in SWOG and the NCTN. We have 2 Seed Fund Awards to announce. The first is to Dr. Noelle Aring of the University of Michigan, whose award will support her project, Hypnosis for Pain in Black Women with Advanced Breast Cancer. Please note Dr. Aring personally directed me to pronounce her name like a pirate, so that is what I had to do for the funny looks you guys just gave me. The second award is to Dr. Joe Unger, PhD, and Via Raja, PhD, of our Statistics and Data Management Center for their project Socioeconomic Disparities in Patient-Reported Outcomes Among Cancer Clinical Trial Participants. Let's congratulate these Seed Fund Award recipients. The SWOG Hope Foundation Impact Award supports the early and conceptual stages of novel, innovative SWOG research projects. We have 3 Impact Awards to report. Drs. Catherine Crew and Richard Ha, both of Columbia University, received an Impact Award for their project, Application of a Convolutional Neural Network-Based Model to Breast Imaging to Assess Prognosis and Predict Response to Adjuvant Breast Cancer Treatment. Dr. Karen Redding of the University of Washington received an Impact Award for a project entitled CCBot, a personalized SMS-based conversational agent to address sleep disturbances in women with poor sleep after breast cancer treatment. The final Impact Award is to Dr. Rakshakar Chakraborty of Columbia University for non-invasive minimal residual disease assessment in multiple myeloma with liquid biopsy and functional imaging. Please join me in congratulating all of them. The Dr. Charles A. Coltman Jr. Fellowship is meant to engage early career investigators in learning clinical trial methodology. Our newest Coltman Fellow is Dr. Elizabeth Brame of the University of California, Irvine, whose project has the particularly catchy title, a Phase 2-3 randomized study of our mini-CHOP, with or without oral azacitidine in patients age 75 or older, with newly diagnosed diffuse large B-cell lymphoma, grade 3B follicular lymphoma, transformed lymphoma, and high-grade B-cell lymphomas with MYC and BCL2 and or BCL6 rearrangements. Please join me in congratulating Dr. Brem and mostly myself for getting through that in only 3 breaths. Our Career Engagement Award ensures protected time for mid-career investigators to pursue clinical research. Our most recent Career Engagement Award is to Dr. Eileen Connolly of Columbia University for S2003, a Phase 2 study of intraoperative radiotherapy for DCIS after breast-conserving surgery. Again, let's extend congratulations to Dr. Connolly on her Career Engagement Award. The VA Integration Support Program Award provides funds to Veterans Health Administration medical centers to enable their participation in NCTN clinical trials. It served as an important program allowing the successful launch of Navigate at the federal level. The latest VA Support Award is to the VA Northeast Ohio Healthcare System in Cleveland. Please join me in congratulating them. The final awards I'll announce today are the first given under the Encore Pilot Grant Program, which funds projects to increase the representation of underserved populations in cancer clinical trials. The first award is to Dr. Jamie Fukui of the University of Hawaii Cancer Center for expansion of a successful intervention to increase NHPI accrual to clinical trials in an underserved rural community on Oahu. The second Encore pilot grant is to Dr. William Robinson of the University of Mississippi Medical Center for a project entitled Improving Participation of Underrepresented Populations in Clinical Trials. Let's congratulate both of our inaugural Encore pilot grant program recipients. So, want to see your name on these slides in an upcoming group meeting plenary? Here are the award deadlines to hit. Applications and details are, of course, all available at thehopefoundation.org. To fund these awards and so much else that they support within SWOG, hope depends on the generosity of donors, in part, your generosity. I donate every year because I believe in the work we do. It's usually on December 29th, but hopefully this reminder will help us all give a bit earlier for, planning purposes. Here's a list of the top 10 SWOG member donors to HOPE in 2021 listed alphabetically. An anonymous donor, William Barlow, Rizal Kurzrock, Benjamin Marcello, Robert Orlowski, one of today's podium presenters, Raymond Osar-Arjuban, Dana Sparks, Norbert Strauss, Debashis Tripathi, and Mark Zalupski. Now, listing only the top 10 donors could be seen as rather elitist. It's important to recognize those who give consistently as well. So here's a list of HOPE's most faithful donors. All those on this list have given annually in support of HOPE, probably since at least the Obama administration. Kathy Albane, Patricia Arlauskas, William Barlow, Joshua Mammon, Haley Moore, Patricia O'Kane, Robert Orlowski, Dan and Michelle Phillips, Lahosh Pushtai, Dana Sparks, Debashis Tripathi, and Mark Zalupski. Let's congratulate them. HOPE is definitely SWOG's future. Finally, before we move on to our plenary presentations, I want to take a moment to recognize an important HOPE anniversary. Our own Jo Horn, President and CEO of HOPE, has now been with the HOPE Foundation for 15 years. She's run the foundation for the vast majority of that time, wearing an astounding variety of hats to the huge benefit of both HOPE and SWOG. Jo, we owe you a debt of gratitude, far beyond gratitude, but all I can say is thank you for your 15 years of commitment, wisdom, and truly admirable leadership. Please stand up so we can all embarrass you. Speaking of Jo and donations reminds me of an amusing story Jo was telling me just last week. A nice, clean, non-offensive, only mildly boring, amusing story. It seems Jo got an unexpected phone call that apparently went something like this. Hello, is this Joe Horn? It is. This is Agent Schmendrick from the IRS. Can you help us? I'll try. Do you know Dr. Charles Blinky? I do. Is he a member of the SWOG Cancer Research Network? He is. Did he donate $10,000 to the Hope Foundation last year? He will. So that ends my plenary updates, and now I want to introduce our plenary presenters. Our first presenter is Dr. Robert Orlowski, chair of SWOG's Barloghi-Salmon Myeloma Committee since 2011. Dr. Orlowski is interim chair, director of myeloma, and the Florence Maud Thomas Cancer Research Professor in the departments of lymphoma, myeloma, and experimental therapeutics at the MD Anderson Cancer Center. A translational researcher who hates myeloma, his words. He is also co-PI of MD Anderson's high-risk myeloma moonshot grant and is a myeloma pioneer on Twitter. With a year of progress in myeloma research, here's our first speaker, Dr. Orlowski.
Well, Gar, thank you for the introduction. So it's a pleasure for me to be invited to speak about myeloma and give you an update on some of the exciting things happening in the field as a whole, as well as SWOG's role in that. And I've got my disclosures up here again in case you didn't look at them earlier. Some of you may remember myeloma from years ago as being a nasty disease, and unfortunately it still is, but the good news is that people are doing a lot better than was the case at that time. And here, for example, is an analysis of SEER data looking at the period between 1975 and 2017. And the good news that you can see is that the mortality is going down now for several decades among Caucasian, African American, really all of the subgroups. Of course, we'd like it to go down a lot more quickly than what you see, but it is heading in the right direction. Interestingly enough, though, the incidence of myeloma is increasing slowly. And of course, the prevalence is going up. Part of that is for a good reason, that people are living longer. But the bottom line is that myeloma continues to be an important healthcare challenge, both in the US as well as internationally. There are improving outcomes. This wasn't meant to say improv the outcomes. We just have a little bit of overlap. Maybe you don't have that on your screen. You have the full slide. On my screen here, there's an overlap. You can see myeloma in the bar graph there has been, at least in the heme malignancy space, one of the areas that has grown the most, meaning the greatest improvement in benefit, and this is the 5-year overall survival. Just to kind of show you where things are, I went back a few years, shall we say, maybe around 20, and this was a slide that I gave in a talk many years ago about new therapies for relapsed refractory disease, and this was about a combination of thalidomide with dexamethasone. Thalidomide is a drug that we now don't use for the most part at all, and you can see the response rates and complete response rates were rather modest. And these are the current NCCN guidelines. You can see at the bottom, by the way, that it says version 5 in 2022. So that shows you how quickly things are changing. And there are multiple category 1 options to the point that people often have trouble picking which of these is the best at a particular point in time, which in some ways is a good problem to have, although we'd certainly like for it to be more biomarker driven. Some of you may also remember that myeloma, not unlike other cancers, goes through a progression starting with precursors, which sometimes are not diagnosed, but they include problems like MGUS or monoclonal gammopathy of undetermined significance, then either what's called smoldering or asymptomatic myeloma, and then clinically symptomatic disease. And this is the old view of evolution of myeloma, where you start with these precursors and then some kind of changes happen, maybe additional mutations, maybe immune problems, but eventually you get progression. And now with some of the single cell techniques that we have available, and I pulled out just one study that looks at clonal evolution, we're now able to map some of the changes that occur and hopefully in the very near future get very much closer to personalized therapy targeted to these various clones. One of the interesting things, though, that we find, and many of you that are in the solid tumor space are lucky to have various mutations that you can target with very good drugs. In the myeloma space, it's a little bit more difficult because it turns out by the time you have symptomatic myeloma, which is over on the right part of both of these panels, most of the mutations that are found have already been present for quite some time. And so it doesn't look like these mutations themselves are responsible for progression. It seems that there may be some extrinsic factors, host factors, immune factors that are involved. And so as part of that, we've tried to rationalize going after myeloma like many of you do for your cancers with immune therapies. So I'm going to touch on a couple of key concepts and give you examples of ongoing and previous studies. And the main concepts that we've tried to follow both within our committee and the field as a whole is, of course, to do everything that we can to study the biology of the disease. Patients make a significant sacrifice to be on trials, and I think we owe it to them to learn as much about their disease as possible beyond just the actual treatment questions. It sounds simple to say, but use your best drugs early is a theme as well. There's always been a debate in myeloma about should you use a couple of drugs, and because everybody eventually relapses, maybe save something for the relapsed setting. Now, I think we feel that that probably isn't best. In part because we're not eradicating all of the myeloma cells, we do tend to apply continuous therapy rather than a defined set of cycles. We also have been, of course, leveraging immunotherapy approaches, trying to use minimal residual disease testing to guide therapy. And then what I think we're really excited about is hopefully designer drugs that can be targeted to certain molecular subtypes. So I'll start with SO120, which is an example of an attempt to really try to understand the biology of the disease. And Madhav Dadapkar, who was at Yale at that time, along with Bart Barloghi, were the leaders of this effort, which was really the first one to follow MGUS and smoldering patients with serial molecular testing to try to understand what changes happen. And this looked both at the myeloma cells themselves as well as the tumor microenvironment. And very recently, one of the publications that came out of that implicated a role for PD-L1 expression as being a predictor and presumably, therefore, a mediator of progression. And this was PD-L1 both on the tumor, as you can see in the left panel, as well as PD-L1 on the microenvironmental cells, which is on the right panel. So in part with that background, lenalidomide, which of course is the successor to thalidomide and a drug that is used in newly diagnosed symptomatic disease, but that does downregulate PD-L1, was looked at in a large intergroup study for its potential benefit in the smoldering setting. And this was a study comparing observation to lenalidomide. And here in this curve, what you can see is that the progression-free survival was better for the lenalidomide group, which is in blue, compared with the observation group, which is in red. The overall survival so far has not yet changed, and it may be that we need longer follow-up, but when you consider that the progression is often allowed with things like bone disease or renal failure, just reducing progression-free survival may have a benefit. We also have done new induction therapy trials, and triplet regimens are now the standard of care, but that really was established by Swog, and the trial that really did that is shown here. Brian Dury was the leader of this study, and it looked at whether lenalidomide and dexamethasone or bortezomib with lenalidomide and dexamethasone was the right way to go. And so this was a large phase 3 randomized study that allowed for stem cell collection, but did not include high-dose therapy with autologous stem cell transplantation. These were updated data published a couple of years ago in 2020 showing that the triplet combination here had a better complete response rate, as you can see across the top row, also a better very good partial response rate, which for those of you that are not in the myeloma field means at least a 90% reduction in disease burden, and a better overall response rate as well. And this was interesting because the bortezomib, the V here, was only given for the first 8 cycles, and then everybody got just lenalidomide and dexamethasone. These are the long-term outcome data, so progression-free survival was better for the triplet in red versus the doublet in blue. And very interestingly, the overall survival was better as well. And so that really gets at that point that using your best drugs up front is going to result in a better outcome in the long run. That was followed very recently by a study looking at high-risk disease. Now, myeloma comes, if you will, in 2 flavors. There's quote-unquote standard risk. Those patients respond very well and tend to stay in remission longer. Fortunately, that's about 80% of patients. Unfortunately, about 20% have molecularly high risk. They also respond well, but relapse much more quickly and have a shorter overall survival. So Saad Usmani built on the previous experience with VRD to try to look at adding a monoclonal antibody to that approach. And the monoclonal that we picked was elotuzumab, which really engages natural killer cells, among others, and is quite effective in the relapsed and refractory setting. So I think there were 2 concepts that were important here. Number one was, does adding immunotherapy make a difference? And the second one is that we elected to continue with maintenance after an intensive induction because of the feeling that that would really improve long-term patient outcomes. Now, here are the progression-free survival data, and it doesn't take a statistician to see that adding the monoclonal antibody in this case was not of benefit. And here are the overall survival data, which suggests that maybe the antibody is making a difference, but we really powered this to essentially try to hit a home run. And so this was underpowered to show the small apparent difference here. But the good news is that the overall outcome on both arms in terms of PFS and OS was substantially longer than what had been expected based on other data. And so it did support this concept of continuous therapy. Now, part of that, I think, is a failure of the induction to completely eradicate the disease, but at least until we get to the point that we can do that, it does appear to be important to keep hitting away at the myeloma. One of the more important developments in the field has been the development of CD38 monoclonal antibodies. You probably remember that myeloma cells have high levels of CD38. It's one of the markers that's used to evaluate plasma cells. And it turns out that these antibodies have multiple potential mechanisms of action. First of all, CD38 is an ectoenzyme, and so binding with the antibody inhibits that activity and induces direct pro-apoptotic effects. Also, binding of these antibodies does attract phagocytosis and cellular cytotoxicity, and there may be a role to play for complement fixation. So it really brings in multiple immune mechanisms in addition to its direct effect. One of the studies that I would highlight here is this trial that Terry Parker led, And this was a study in AL amyloidosis. Now, this is a plasma cell disorder related in some ways to myeloma, where the monoclonal protein tends to form clumps or fibrils in various organs. Most commonly, you can get neuropathy, you can get cardiac involvement, you can get renal involvement, and the morbidity for these folks is quite high, in part because they often are not diagnosed until they're late in their disease course. But we did try this drug Cytoximab, which is one of the CD38 antibodies there. And the latest update of this study, which is now being prepared for a manuscript, is that there was a 77% hematologic response rate, which is much higher than anything that's been seen in this disease before. And we're now waiting for organ responses. Unfortunately, once the fibrils are deposited, it takes much longer for the body to get rid of them, and therefore the organ responses are delayed. But certainly a good hematologic response rate is an important part of that, because you want to kill the myeloma cells that are making this protein to begin with, and then hopefully start reabsorbing them. And I'll get to one we may be doing to help with that part a little bit later. We also have an active study in the maintenance setting post-stem cell transplant, and this is led by Amrita Krishnan. Right now in the post-transplant setting, lenalidomide single agent is the standard of care, and this roughly 1,100 patient study is going to do 2 randomizations. The first one up front is to look at len single agent versus len plus daratumumab, which is the other CD38 antibody that's available. And then with the goal of using MRD, which is one of the themes I mentioned at the beginning. After 2 years of maintenance, there are MRD measurements that are done. And then if you are MRD negative, you get randomized either to continue with maintenance or to stop maintenance. The goal here, of course, is the hope that with MRD negativity that's sustained, you may be able to hold on treatment for a period of time before you have relapse. And that will, of course, help patients because they're always happiest and have fewest toxicities when they're off of therapy. And from a financial toxicity perspective, it would be a great benefit as well. And we're using this clonoSEQ or next generation sequencing assay to measure MRD, which allows us to identify the particular VDJ sequence present in only the myeloma cells, and then much more sensitively than with just an M protein measurement in the blood or urine, then follow on with that in the future. And we can measure this down to 10 to the minus 6th. And hopefully in the future, although right now this is a bone marrow test, but there are ways that we're working on trying to turn this into a blood test. The update for this as of earlier this year is that we've got more than half of the patients already registered and randomized. We have the Canadians coming on board, so we should be able to finish this study at least a year ahead of what had been anticipated. I should mention that all of the studies that I'm showing you were done at least on or ahead of the planned deadline, and so we really have had great engagement from all of you, and I did want to take the chance to thank all of you for that. We also have patients with myeloma that are frail because of comorbid medical conditions, or in some cases because of, how shall we say, excellent levels of maturity. And we don't know what the standard of care there is, but it's probably not going to be 4 or 5 drugs because that's a lot to ask somebody in this range to take. So what we're doing, and this is being led by Christine Yee from Michigan, we're doing a 3-arm study where we're comparing the 2 3-drug regimens that are most often used, have never been compared head-to-head in any population, and certainly not in this one. And you can see that one arm, which is over on the left, will be bortezomib, lenalidomide, and dex in an attenuated dose schedule to allow for improved tolerability, followed by lenalidomide maintenance. The middle arms will be daratumumab, the CD38 antibody, with len and dex, followed by lenalidomide maintenance. And then on the right, you've got, again, dara, len, dex, but this time dara with len as maintenance. So we're going to look at 2 different 3-drug inductions and also look at which maintenance is the best. And we have a large array of correlative studies, which we hope will even help us predict which patients will respond better to which of these therapies. Now, I mentioned earlier that with amyloidosis, part of the problem is that these fibers are being deposited often years before people are even diagnosed and damaging various organs. This is Dr. Divya Bhutani, who's doing a study with an antifibril antibody. So this drug actually has no effect against the myeloma cells themselves, but it does recognize an epitope which is only available when these proteins are in a fibril, and it seems to work in part by helping to mobilize these fibrils out of organs. You can see, for example, in that middle panel that you can label this antibody and use it to detect the presence of amyloid, in this case in the liver. And we're going to be looking at this in a couple of settings, but in particular it will be looking at folks with residual organ dysfunction. Some of you also have had the opportunity to work with bispecific antibodies, and one of the favorite targets for this in the myeloma space is BCMA, or B-cell maturation antigen, because it is highly expressed on plasma cells and a few plasma cell precursors, but pretty much not on other cells in the body. And there's a number of these molecules that are in the clinic. None of them have yet been FDA approved, but I did want to highlight this one, which is probably the furthest along in development, which is Teklistamab. And this paper, which was from a company-sponsored study, but nonetheless you may recognize the first and last authors, who are both SWOG investigators. And you can see here that in the relapsed refractory setting, after multiple prior lines of therapy, patients are achieving very deep and durable responses with this drug as a single agent. So this is really quite exciting. And you can see response rates running in the 60 to 70% range, which is better than any drug that we've seen in this setting before. And presumably they will work even better earlier when patients may have less T-cell exhaustion, for example. So we do have a plan for a high-risk replacement study to the previous trial that I showed you with VRD plus or minus elotuzumab, and Brea Leipe from University of Rochester is leading this, and the plan is to do bortezomib len dex with dara as the control arm, and to add this BCMA bispecific to the experimental arm and see if driving the level of MRD downward even further will be of benefit to these high-risk patients. And before I wrap up, I did want to just give you maybe some views of what could be happening in the future. These are some preclinical studies. I'm a translational researcher, so I think I'm contractually obliged to show mice in at least every presentation that I give. So these are still some preclinical studies, but it turns out that one of the interesting things about deletion 17p, many of you deal with this abnormality in your tumors, and you know that it's a high-risk molecular feature. It's also a bad actor in myeloma. It turns out that there's a gene very close to TP53, which probably drives the poor prognosis in these patients, but the gene nearby is POLR2A, which can be inhibited with amanitin, which you may remember from mushrooms in medical school, hopefully just reading about them and not being exposed to them. And here what you can see are preclinical data with an antibody drug conjugate, which targets BCMA and has amanitin attached. The mice across the top row have a control antibody. The mice across the bottom row have a currently FDA-approved antibody that does not show any specific activity against deletion 17p. And the mice in the middle row have this amanitin drug conjugate. And so you can see that there is preferential activity against the deletion 17p mice. So this may be a drug that will be able to use and improve outcomes. We also have immunomodulatory novel antibodies that are able to mobilize immune effector cells. This is one antibody against a target that, if you're interested in, we can talk about offline, but you can see that this antibody targets HSP70 or heat shock protein 70, which is extracellular, and actually induces both NK cells as well as monocytes to upregulate TNF-alpha, TNF-beta, and trail production. And these, of course, induce anti-tumor effects. And then we also have a novel antibody drug conjugate, where here we're testing it against a syngeneic model of myeloma. And you can see in that rectangular box that with treatment, the monoclonal protein is slowly declining over time. And there are a lot of very exciting drugs like this that are coming. So before I wrap up, I thought I'd give you a little bit of a viewpoint on where myeloma will be in the short, intermediate, and long term. Actually, I tried to look in my crystal ball, and this was kind of the message that it gave me, but nonetheless, we'll try to see what I can tell you. I think in 2 years' time, we're probably still going to be doing what we do right now, which is for smoldering, it'll be a watch and wait versus a clinical trial. For newly diagnosed, it'll be triplets versus quadruplets, and stem cell transplant for those who are eligible, and maintenance will be either a single agent or a doublet. As we do now for people in 1 to 3 prior lines of therapy, triplet combinations will be used, and we do now have bispecifics, as I showed you, and also CAR T cells versus investigational agents for later lines of therapy. Down the road, I think we'll be using triplets in high-risk smoldering myeloma, and probably quads, maybe 5 drugs for induction. I think transplant will be used for standard risk myeloma consolidation, but maybe CAR Ts for high-risk myeloma with some kind of maintenance. And again, early relapse will be triplets, late relapse will be additional CAR T cells. And in 10 years, what I think will happen is that bispecifics or vaccines will be used for smoldering, probably bispecifics during induction. We have a study that is planned with a single agent bispecific in a window design, probably transplant versus CAR T, but only if you're MRD positive. Maybe no maintenance. That would be my ideal, because that would mean that we've killed off enough myeloma cells that we don't need to continue people on treatment. And then BCMA targeted bispecifics or CAR Ts in the 1 to 3 prior lines of therapy. So the good news is we've come a long way in myeloma, and outcomes are better than ever. The average survival now is probably 7 to 10 years, and in some cases 10 to 15 years versus 3 years when I started in medical school. We still have a long way to go because we probably don't yet cure anybody, so we can't get too happy, but we definitely have more tools than we've ever had, and I think that gives me confidence that probably within the next 5 to 10 years, we can use that CURE word and be truthful about the possibility of no relapse in the future. And I did want to thank all of the people who are involved, and I think this was supposed to be an animation showing different folks, but I'd like to thank all of you for contributing to these studies, and of course all of the statisticians and the data managers, the principal investigators, and the study leaders, without whom I wouldn't have anything to talk to you about up here. So thanks very much.
We should have time for 1 or 2 questions, including folks on chat. Or it was crystal clear.
There you go. Thank you very much.
Well, that was great. Thank you so much. So we're moving on to Dr. Thompson. Ian Thompson was named chair of our GU committee in 2009, the president of Christus Santa Rosa Hospital Medical Center in San Antonio, Texas, and emeritus professor at University of Texas Health Science Center. He has been a SWOG member for many years and was PI in one of our most important signal prevention studies, the huge prostate cancer prevention trial, which was launched in the 90s and which established the chemopreventative benefit of finasteride for many, many men. Today, he will update us on a year of progress in GU cancers, and I hope show us a crystal ball for the future as well. Dr. Thompson.
Thank you, Chuck. Well, it's nice to be with you, and I think I like Bob, this is really going to be a testimonial to the work of a lot of people. And I'd like to describe to you, first off, what the GU committee is. It's really 4 committees, because we have 3 organ sites, bladder, renal, prostate, and we also have a remarkably talented and productive translational medicine team led by Dave McConkey. Each of our organ sites are led by organ site chairs, a combination of a local chair and an advanced chair. And our Encore activities are critically important partnerships for us. Important as well is that we have 3 patient advocates, Peggy, Rick, and Tony, that kind of always keep us grounded as to why we come to work and why we work here. And I'd like to tip my hat to this group of folks that you see here. If you remember when JFK was hosting a group of Nobel laureates in the White House and said it was the most talented, most intellectual group here since Thomas Jefferson dined alone, that's the group of people that we have to work with. We are passing the baton, and I think everyone in this room probably knows Dr. Nick Vogelsang, who was vice chair of the GU committee for 15 years. Anything that happened that was good was related to Nick. Any problems, they were probably my doing. And we're very grateful. But we're also grateful that Dan Petrolak from Yale, who could not be at this meeting, but is with us in spirit, are being Nick's shoes are aptly filled by Dan, whose picture I will show you momentarily, who led one of the pivotal studies a number of years ago. And the fascinating thing is that I don't know how many of these folks that are leaders began as young investigators in the GU committee. Our goal, our sole goal, sort of, in life, we enjoy getting together in other aspects of participating in SWOG, but our sole goal is to change the standard of care to improve the care for GU malignancies. And I've listed only a few of these critically important ones. Cytoreductive nephrectomy. When I started my residency, if you did a nephrectomy in a patient with metastatic disease on your oral boards, they would send you back to repeat your residency. We changed that standard of care, and I'll show you momentarily that we're about ready to change that standard of care, perhaps again. Adjuvant radiotherapy for locally advanced high-risk prostate cancer is now part of the standard of care for the management of that disease. BCG, once upon a time, non-muscle invasive high-risk bladder cancer, the treatment of choice when I started my residency was a cystectomy. Now, BCG allows bladder preservation and long-term cure. Superiority of maintenance BCG, again, now standard of care for the management of the disease. Adjuvant intravesical gemcitabine more recently, reducing significantly the recurrence after resection of bladder cancer, and a myriad of studies related to metastatic prostate cancer. In fact, Maha's sitting back there, Maha Hussain, who ran the continuous versus intermittent androgen deprivation trial, one of the plenary session presentations at ASCO a number of years ago, and pointing out Dan and docetaxel became the first really standard of care for advanced prostate cancer. There's Dan on the left, as you can see, with the improvement with docetaxel versus mitoxantrone, led to the FDA registration of docetaxel. And on the right is our good friend Bob Flanagan from Chicago, who changed the standard of care for advanced kidney cancer with cytoreductive nephrectomy with SWOG 9916 and 8949. I think I've been participating in SWOG for 40 years, so I actually remember those numbers. So a few characteristics of the committee that we think make this possible. One is that we are participatory. We have 246 members. 38% of those members are either an organ site chair, a TM chair, translational medicine chair, a discipline chair, study PI, co-PI, NCTN study champions, patient advocates, or TM or other authors associated with these studies. And our goal is actually to improve on that. We want every single member of our committee to be thoroughly engaged in the participation to really make a difference in the care of these patients. The second attribute is that we are collaborative. As you look on the far left, Melissa Pletz made this possible through this analysis of GU trials over the past 5 years in the NCTN. On the far left are the SWOG. So we accrue to our own trials, but we also participate in the other NCTN trials because they are also important in changing the standard of care. The way we do so is by nominating study champions. This is a small portion of our grid. So each of the trials numbers and the description are the first and second columns, and the champion is off to the right, who interacts with the other cooperative group and is the advocate for that trial within our institutions. I think I'm probably proudest of all of the work that our committee has done with regards to trial prioritization. When I began, I inherited 15 trials in production in the GU committee. We have a remarkable statistical and operations group teams, but the ability to prioritize their work on 15 studies was nary on to impossible. So we have a merit-based RFA process. It helps us to focus on what is the highest priority, which I'll talk to in a moment, but we're also nimble. And so that when we have the opportunity, when a task force or when the NCI comes to us with an opportunity, we can respond to that. We're able to activate 2-3 studies a year, depending upon the load, but when we're running trials that are FDA registrational trials on a repetitive basis with embedded biomarkers and embedded other studies, it does put a pretty significant strain, so it's very important to prioritize. I'll point out to you our prioritization process. We use an NIH scoring mechanism. Clinical relevance, will the study accrue? Is it feasible? How does it fit into our portfolio? What is the potential for transformative correlative science? The leadership team, and I note in here that we also include the inclusion of a young investigator in the leadership team. Our expectation is that the trial will have a young investigator and a seasoned investigator, because most folks will not be at SWOG for the next 100 years. We need to have the next group of folks participating. Finally, obviously, competing studies. And by the other aspects that we do with regards to our young investigators, obviously we add points to the score if there is a young investigator involved in a proposed trial. And then at the bottom where I say we time our RFAs. So we want our RFA to select incoming studies at the same time that the young investigator training course is inviting folks to participate. And we have a number of our trials that are currently finishing up that the young investigator was the PI and is now a more seasoned investigator in reporting on that trial. So as you can tell, if you're going to change the standard of care, you have to ask innovative, dogma-busting questions. And ideally, because we are urologists, medical oncologists, radiation oncologists, radiologists, urologists, pathologists, you name the specialty, and it's a very nice distribution of all of the above. Ideally, it should be multidisciplinary. An example is this. This is Harry Herr's review of one of our trials that we reported originally, the original MVAC trial, that recognized that it was the outcomes were superior for the patients who had 10 or more lymph nodes in the lymphadenectomy specimen at the time of cystectomy. And based on this and other anecdotal reports, many of my colleagues around the country and around the world are now doing extended lymphadenectomies at the time of cystectomy for bladder cancer, for muscle-invasive bladder cancer. You have to understand, however, that a cystectomy is a very morbid procedure. high perioperative 90-day mortality rate, readmission rate between 35 and 40%, and even the very best of institutions. If you add another 30 to 60 minutes of anesthesia time to a frail patient who's got vascular disease, all you're going to do is to increase the potential adverse outcomes. So the question about this, and because we know that the same kinds of studies led to the change in the management for gastric and pancreatic cancer, and when they were studied in randomized trials, did not improve survival, only increased complications. Seth Lerner led the development of 1011, which is a randomized trial of a modified node dissection versus an extended lymph node dissection. First time this has been done to our knowledge in the NCTN. And the question is, how do you do the QC for this? Well, the answer was surgeon credentialing. And Seth and his team put together the essential elements of a credentialed surgeon to be able to do this, so we could credential them. Oops, go back one. And we had a team that reviewed the checklists, this credentialing committee, the individuals that you see on the right, Dr. Skinner, Lerner, Svatek, and Koppy. And then we had a consensus review, and the patients could not be registered until the surgeons were credentialed. It's also a wonderful trial to change the standard of care. Lots of different outcomes. One is that the extended node dissection improves the outcomes, reduces recurrence rates, improves survival. That will change the standard of care. If there's no difference, oops, going back too fast. If there's no difference, we go with the modified because we know that that's going to be associated with lower complications. And if the modified is superior, obviously go with it as well. So it's a wonderful kind of trial that no matter the outcome, it will change the standard of care. Bob pointed out earlier that he remembers, and these are really remarkable changes that you reported with regards to myeloma, really remarkable. When I started my residency a long time ago, the median survival for advanced hormone-naive prostate cancer was 18 months. Now we are seeing these dramatic improvements over time, and Dr. Hussein's continuous versus intermittent trial, the continuous arm, you can see the significant improvements in median survival. When we began a trial that I'm going to talk to you about momentarily, we used the second-line treatments, for example, the approval of docetaxel and other treatments, to estimate the improvement in median survival so we could calculate the sample size for this trial that I'm going to show you here, which was 1216, Niraj Agrawal's trial, testing orterenol, which is a lyase inhibitor, more specific compared to bicalutamide combined with standard androgen deprivation therapy to see if we could further improve overall survival. This is the progression-free survival differences that Niraj has reported, really dramatic differences. But what has really been amazing and is wonderful to see, because all of us who treat patients, this really comes down to the individual patient, is that although there was not a significant improvement in overall survival, that overall survival that you see there with orterenol, which is TEC 700, the median survival was 81.1 months. When we stack it on top of that original publication that you see on the left, with that series of improvements in overall survival, look at the difference that we're seeing today because of second-line therapies that we're seeing with the disease. Another way that we're able to change the standard of care is responding to science and responding to need. And in the area of superficial bladder cancer, where the GU committee established BCG as the treatment of choice for CIS, T1, and recurrent TA disease, BCG standard of care. The challenge with it is that you can see there are two outcomes, two Kaplan-Meier's on the far left. Connaught used to be a producer of the BCG. It's a tuberculous, BCG is commonly used for vaccination against tuberculosis. And Tice, which is manufactured by Merck, is another producer. Well, Connaught went offline. Their factory closed down, and all of a sudden you see on the far right, and there were multiple reports of where we can't get BCG. In fact, at the bottom, you can see we began getting guidelines on how to dilute BCG to split the vial so that you could give it to multiple patients. And there were many patients who were not being offered this treatment, which is really life-saving and prevents the need for cystectomy. Well, Rob Svatek had been partnering with folks from the Pasteur Institute in Paris. Rob has his own laboratory with a suggestion, observations that especially in other countries like Europe and Canada, where a large fraction of healthcare providers and others receive BCG inoculations. These are intradermal inoculations to prevent tuberculosis. If you were PPD positive at the time you were given the BCG, you had an improved outcome. And there's an entire science behind T-cell priming with BCG. So Rob began this 3-arm clinical trial, and you talk about a challenge from the tip of the hat to Dana and her team, Kathy and her team for this. This is a trial taking a biologic from Tokyo, Japan Biologic Laboratories, JBL. This is the Tokyo strain of BCG, bringing it into the United States because with Connaught going offline, there was no approved way to give intradermal BCG with the same line. So the 3 arms, one just intravesical TICE. This is the standard of care that was diminishing in its availability in the United States, versus intravesical Tokyo, versus priming with the inoculation followed by intravesical. And the wonderful thing about this is that there are 2 primary objectives. One is that if BCG proves to be, the 2 strains prove to be non-inferior, all of a sudden we have another BCG strain to be able to offer our patients. And the other primary objective is we may find that priming, the science suggests that it ought to work, priming may improve the outcomes, and either one of these would change the standard of care in the United States. And given a choice of being smart or being lucky, choose lucky anytime, because this trial activated about the same time that the BCG shortage began, and you can see what happened when Merck made it available for the study itself. So we were concerned that the patients who were randomized to the TICE strain we would not have available. They preferentially made it available, and there are entire centers in the United States that the only way they could treat their patients with bladder cancer was to register patients on the trial. We had a small dip when JBL had a little problem with her diluent, but we finished the study accruing far faster than was expected. Again, a shout out to Merck for making this available. Obviously, lots of benefits. If priming improves control, we've changed the standard of care. No matter what, this will change the standard of care. We're constantly learning and asking questions within the committee. Just like the NCI, we hold symposia to evaluate current science and drive future trials. The PRIME study, that last study, the BCG trial, came out of a symposium that we held at a SWOG meeting a number of years ago on immunotherapy and bladder cancer. Treatment of the primary tumor in patients with advanced prostate cancer, advanced cancer, treatment of the primary led to the development of SWOG 1802. I'll show you that in a moment. The cytoreductive trial came out of the immunotherapy. And visualizing the future, earlier today we had a symposium at 9:30 run by James Yu and Dan Hamstra on a radiation therapy targeting oligometastatic disease. And we actually had presentations on lung cancer outcomes, lung cancer clinical trials, but primarily in GU. And Saturday at noon, please stay and join us for our DEI symposium. Obviously, we continue to reevaluate our prior conclusions. 1931, the PROBE trial led by Ulka Vaishampayan, who you see her picture, is asking the question whether cytoreductive nephrectomy is still germane in the era of immunotherapy for kidney cancer, because there's 2 possible biologic explanations for why it might not. For example, if you have a higher antigenic load with the primary in place, you may have a better outcome. The other possibility is that by removing it, you may actually be able to improve the ultimate immunologic response. And by the way, a patient with advanced kidney cancer undergoing a radical nephrectomy, the risk of complications are potentially substantial. So we will no matter what the outcome, we will again change the standard of care. And this is Brian Chapin, as you can see at the bottom right from MD Anderson. Brian's trying to help answer a question that in some institutions, the horse has already left the barn. We don't know that management of the primary and advanced prostate cancer makes a difference in overall survival. And nevertheless, around the country, patients are receiving radiation and sometimes even surgery for the management of this disease process. Brian is conducting the study of standard systemic therapy, which is basically androgen deprivation therapy, versus radiation or surgery to look at the overall survival outcome. And we have a lot of accrual to that. Earlier today, this was the Radiation Oncology Symposium that I mentioned just a moment ago. And tomorrow, this is our DEI Symposium, which has an all-star cast speaking about how SWOG and specifically the GU Committee can make a difference. Penultimately, again, running out of time, there's insufficient time for two other important areas. Tip of the hat, and I didn't include it in this because you heard it yesterday, Dave McConkey leads a remarkable team of translational physician scientists who oversee multiple studies. Many of these are supported by R01s. And cancer control, we have 5 studies ongoing and 1 concept. Finally, and most importantly, I'd like to tip my hat to our data coordinators and clinical research associates. It is a major, they are as important as anyone else in the conduct of our clinical trials, especially during these challenging times. They've stepped up and made these trials possible. They're the real heroes of the GU Committee. And as you can see, it really takes a smart, enthusiastic, diverse, and engaged village for this to be possible, all 246 members of them. Thank you.
In case we have a question. Questions? No. Thank you, though. So our final presenter on a year of progress in Encore research is Dr. Dawn Hershman, Director of Breast Oncology and co-leader of the Cancer Population Science Program at the Herbert Irving Comprehensive Cancer Center at Columbia University. She has, of course, co-chaired our Cancer Care Delivery Committee and its predecessors since 2008, has served as SWOG Vice Chair of Encore Research, in charge of our Encore Research since 2015, and is co-PI of our Encore Research Base Grant. She was named a Giant of Cancer Care by OncLive in 2021, but we knew she was a giant of cancer care and cancer care delivery research years before that. Dr. Hershman, please take it away.
Well, thank you. It's always really a privilege to be able to present really the outstanding work of our whole team on the Encore side. The mission of our SWOG Encore research base is to rapidly design, activate, and complete biologically driven, scientifically important, and clinically meaningful studies in cancer prevention, cancer control, and cancer care delivery. So whenever we say Encore, it's always a little bit confusing because it's one word for many things. So the Encore research base, our mission is to fund studies, to conduct studies that are funded by cancer prevention, cancer control, cancer care delivery sections of the NCI. Our Encore community sites and minority underserved sites are the sites that actually recruit patients to trials. But the research base, our function is just like the NCTN to conduct and design trials. Our Encore leadership, you can see on the slide, we have executive officers, and we have 5 committees. One that focuses on prevention and epidemiology, 1 that focuses on cancer care delivery, and 3 that cover cancer control, focused on symptom management and quality of life, survivorship, palliative care, and end of life. And you can see the committee leadership in this slide. So we've looked at the past 5 years to sort of at our successes. We've accrued a lot of patients to our Encore trials, over 7,000. 29 concepts have been submitted to triage. We've had 10 activated trials. 15 grants that have been submitted, 6 funded, 4 resubmitted, 188 manuscripts, 111 abstracts. So since the last grant, we developed a PRO, patient-reported outcome, core resource. The goal of this resource, SWOG PRO core, is to provide the scientific oversight and input into patient-reported outcome designs in all of our trials. The goal of this is to really ensure that there's rigor and that the sub-studies conducted are really done according to SWOG standards, and to ensure there's consistency in our outcome measures, and this serves as a repository for future studies. Our PRO core has overseen 22 quality of life sub-studies in SWOG randomized clinical trials on the treatment side at this point. We also have a secondary data analysis program within it. And this has been an enormous success. We have a lot of individual grant funding, and we've published an enormous number of high-impact publications, many of which you've read about in Frontline over the past year, focusing on all types of different studies that are important to patients and practitioners. We've looked at issues related to toxicities, such as sex differences in toxicity. This recently got a lot of publication. We've looked at the impact of fatigue and how that impacts outcomes. We've looked at socioeconomic deprivation and how that impacts both outcomes and clinical trial accrual. We've looked at AYA populations and done economic analyses. And the important thing is that many of these studies are led or co-led by junior investigators. We've done a lot of studies that have looked at long-term toxicities to the treatment that we give. And this was an innovative trial published in 2021 looking at the incidence and risk factors for osteonecrosis of the jaw in cancer patients receiving zoledronic acid for bone metastases. You can see that this study showed overall that there's about a 2.8% cumulative incidence over 3 years of developing this toxicity. It's important because many patients are afraid to take these drugs because of the toxicity. There's a wide range based on types of tumor, and that we were able to establish some factors that put patients at higher risk versus lower risk of developing this toxicity, most notably prior dental procedures, smoking history, and dentures, all associated with an increased risk. This serves as a large repository for future research, and ongoing analyses are looking at this. What this study did was it set the stage for us for conducting large cohort studies for looking and understanding toxicities. And it led really to 2 subsequent trials. One is S1714, which is a prospective observational cohort study to look at taxane-induced peripheral neuropathy. This study accrued 1,300 patients. It was closed last fall. There is an abstract being presented at ASCO, and then it led to a subsequent submission of an R01 that should be reviewed this summer. It also set the stage for iCheckIt, which is an ongoing study, which many of you have heard about, looking at immune checkpoint inhibitor toxicity. It's also a prospective study currently enrolling, chaired by Krishna Ganturo, and it will accrue about 2,000 patients. This sets the stage for a large repository of both patient-reported outcomes as well as biologic samples for future studies. We've been very interested in issues related to medication adherence. We know that, for example, aromatase inhibitors are commonly discontinued prior to their appropriate endpoint for women with breast cancer. We were the first group to do a large randomized trial of a text messaging intervention to reduce discontinuation. We found no benefit of ongoing text messages, likely due to the deluge of information people get from texts, but we found enormously high rates of discontinuation in this large trial. This data then led to a subsequent study that allowed us to predict which patients were more likely to discontinue therapy versus not. We were able to develop a risk model. Patients that fell into the highest risk based on their baseline patient-reported outcomes have a 50% risk of discontinuing over 3 years. This then led to other interventional trial, and this study is being led by Lynn Henry. She recently got an R01 grant, something that we have a lot of pride in. A lot of our investigators have grant-driven, grant-funded trials. This study is looking at active symptom monitoring in women that are receiving endocrine therapy. Young women are at particularly high risk, so this is targeting young women who are undergoing ovarian function suppression and using active symptom monitoring to intervene early when patients develop symptoms so as to reduce discontinuation rates amongst these patients. We also do complicated studies, and this is SWOG 1904. The premise of this study is based on the fact that we know that hormonal therapies reduce the risk of developing breast cancer. This study is led by Catherine Crew and Rita Kakofka. They also have an R01 grant to conduct this trial. It's a trial that randomizes sites, so sites are randomized to the intervention or not. It is a study that is looking at both a provider intervention as well as a patient intervention, so both patients and providers are accrued. They've randomized 26 of the 26 sites. Over half of the providers have been enrolled, and about a third of the patients have been enrolled. And conducting these complex studies that will help us move this field forward is something that we really can only do, as was said earlier, with a village of people working on all of the different components of getting these trials up and going. This is a study that we're also very proud of. You've heard before about this trial that is being run by Dr. Nichols and Dr. Nappy, really trying to define the role of microRNA 371 for outcome prediction in patients with germ cell tumors. This is a study we had which was enormously successful. It's an observational study. It's relatively easy to enroll to. The study got approved on first submission to the steering committee, which is almost unheard of. It has not been open for all that long, and yet 465 of the 956 patients, so about half of the patients, have been accrued. Dr. Nappy just found out this past month that she received an R37 award, which is really, for an exceptional research award for an early stage investigator to do all of the biologic correlative work. And so really it's our mission to get these studies going, get them accrued, and help young investigators develop independent research funding that they can use long term. This is one of our surgical studies led by Robert Kraus. It's a comparative effectiveness trial that was funded by AHRQ, really looking at malignant bowel obstruction. Can this be managed with medical management, or does this require surgery? This really deserves a shout out because it was a great partnership with our Latin American sites that helped us accrue. This completed accrual this past fall, and the data is currently being analyzed. This is Virginia Sun, who's a mentee of Dr. Kraus. Again, looking forward on how we can take one study, learn from it, and expand it. This is an R21 funded grant that she was able to get that is looking at managing symptoms in terms of a dietary intervention with coaching amongst patients with GI symptoms that have rectal cancer to prevent bowel obstruction and improve bowel function. This study, I think at this point is, well, it's essentially accrued because there's a two-step accrual process. All the patients have been registered to step 1, and we're also looking forward to these this innovative trial results. This study, in addition to getting an R21, was also funded by the Hope Foundation. We hear a lot about financial toxicity. Our group was the first to do a trial looking at financial toxicity in a large multi-center study. This study was led by Veena Shankaran. It was published just a couple months ago, looking at the cumulative incidence of financial hardship amongst metastatic colorectal cancer patients. You can see here over the course of a year after being diagnosed how extreme material financial hardship is, with 75% of patients experiencing some form of material financial hardship. And this is despite having the majority of these patients having adequate access to health insurance. You can see that it's slightly different if you look at debts or loans, but these are major issues that patients face. This data then went on to help inform now we have the first interventional trial looking at ways to mitigate financial toxicity. And this is SWOG 1912 CD, which is a randomized trial. It's currently accruing patients. It's actually accruing patients and their caregivers or their spouses simultaneously. This was another complex study. Both of these studies involve our patients being linked to their financial records so that we can know whether or not they have submitted bankruptcy or filed for bankruptcy. The trial itself randomizes patients to financial assistance, financial counseling, financial literacy training, and coaching versus just having financial literacy training. So if you don't have this trial open at your institution, please open it. Again, this trial also was funded by an NCI R01. We conducted the first cancer care delivery trial, as this was a new component. And this is a study that was funded by PCORI, led by Scott Ramsey, a pragmatic trial to evaluate guideline-based CSF order, an intervention determine the overall effectiveness of automatic order entry. This had a 2-phase randomization. Patients that had high risk for developing neutropenic fever were either randomized to automatic order entry versus usual care. And then there was a secondary intervention amongst intermediate risk patients to automatic order entry versus usual care. We had never done a study like this. It was highly successful. The sites all changed their order entry system. We were able to accrue rapidly to this trial with over close to 3,000 patients randomized, and the results of this trial will be presented at ASCO. And I want to talk about, how we've moved from doing observational studies to interventional trials. This is a new study that we're also very proud of, looking at an intervention to reduce chemotherapy-induced peripheral neuropathy. The trial's called STOP-CIPN. You can see how we came up with that. It's a randomized trial of limb cryocompression versus continuous compression versus low cyclic compression for the prevention of taxane-induced peripheral neuropathy. What I'm most proud about with regard to this trial is that it's a collaboration with all of the Encores. We have leads from NRG, 2 junior investigators from SWOG and NRG leading it, but input from Alliance as well. We all had spoken to the same manufacturer, Paxman, to do the trial. Rather than competing, we all came together to design the best study together. This study went through our NCI steering committee, and I'm happy to say last month was approved, and hopefully will be open and activated by the end of the year. I really wanted to shout out to the Hope Foundation. The Hope Foundation has given our investigators in the Encore over $3.5 million over the past 5 years. Many of our studies are not funded by industry. They're mostly funded by grants. We have to do a lot of preparatory work in order to define the intervention, define the outcome, and do pre-testing to make sure that our interventions will be successful. In addition, our investigators aren't, funded to do these studies. So we've received, many of our investigators have received Coltman Fellowships, Impact Awards, seed funding, STRS funding, Impact Awards, as I said before, at various different stages. And we're extremely thankful for the Hope Foundation and their support. So with that, I wanted to just end by saying that the goals of the Encore research base are really to generate novel ideas. We're always looking for more ideas, for more to help the careers of junior investigators. We're always willing, and I'm always willing to try to match make and find the right committee for an investigator that has an idea, to have lots of concepts, protocols, and grants approved, to publish lots of papers, to have more community involvement, to focus our research on disparities and health equity research, to encourage advocate involvement, and ultimately to have more impact. Thank you very much.
Stay up just in case.
I don't know if anybody has questions.
Nothing in chat. So just to underscore the importance of your work, particularly the financial toxicity, the state of Oregon issues an annual report every year on why patients and families are considering medical aid in dying or death with dignity. And every year, consistently, between 5 and 10% of patients take their own lives voluntarily because they can't afford their chemotherapy. I assume that doesn't surprise you, but I'll ask you, does that surprise you?
Well, no, I mean, I'm sure that that's one of many factors, but it doesn't surprise me that it leads to tremendous stress, anxiety, and depression.
No, good way to end your talk. Thank you. I set her up for that. Thanks, Don. Okay, so I want to thank all of our presenters, Drs. Orlowski, Thompson, and Hershman, for sharing their time, their expertise, and their narratives of amazing research progress and promise with us today. In fact, I want to give them another hand because we're amazing. In addition, I want to say it has been truly wonderful being able to meet in person again for the SWOG group meeting and to see your faces. So since it's been a while and I know how badly you've missed them, I'm going to tell yet another amusing story. So it seems that Larry is 90 years old. He has played golf every day since his retirement 25 years ago. But one day he arrives home and he just looks terribly downcast. That's it, he tells his wife, Mary. I'm giving up golf. My eyesight has gotten so bad that once I've hit the ball, I can't see where it went. Mary sympathizes, makes him a cup of tea. She says, I've got a solution. Why don't you take my brother Herman with you and give it one more try? No good, says Larry. Your brother's 103. He can't help. Well, Mary says, he's 103, but he's got the eyes of an eagle. So Larry says, sure. He heads off to the golf course with his brother-in-law, tees up, takes an almighty swing, and squints down the fairway. He turns to Herman. Did you see the ball land? Of course I did, says Herman. I've got the eyes of an eagle. Well, where did it go, asks Larry. I don't remember. So please remember the effect our work has on our patients. It's really been a tough 2 years, but I am absolutely convinced we came out better. I want to thank you all for attending the meeting and thank our speakers one last time. Have a good rest of the meeting.